And this is different than any clinic around.
Workouts that are tailored for her, and that really makes a difference.
Really personal. I've gotten way more mobile, stronger, flexible. Just everything just improves me to the next level.
Welcome to the On Q Performance Therapy Podcast, where we push sports performance and physical therapy to its apex. We change the game by bringing together the brightest minds in the field to offer best practices and question how things are done today. I'm your host, Mike Quintons, physical therapist and expert in sports orthopedics. I'm living my dream and opened a clinic that unites all elements of sports medicine under one roof to drive recovery and performance outcomes. What's happening, Performance Therapy Nation? This is Mike Quintons, your host of the On Q Performance Therapy Podcast. I'm joined today by Alanna DiBiasi, physical therapist, as well as Melinda Brooke, who is technically our patient coordinator, but is also slash comedian, slash actress, slash you do fashion too, fashionista. Yeah. And we're diving into a little bit of everything today. What I want to make sure we get into especially with Alanna and Melinda's going to comment because she runs as well, and is gonna offer some different insights from a patient perspective. Is that we jump into what runners deal with, what we look at with runners, how we assess, how we identify, how we alter, how we treat, how we plan. There's a lot of different directions we can go here, so I'm excited to get into this. But first, I want to thank our listeners for subscribing, reviewing, all the above. It's been an amazing first season. Officially, we're going to wrap up the first season with this episode. This is episode 19, and it's interesting and fun at the same time because we have had some wide range of guest speakers in here, and Alanna works at PTW Newtown Square, in-house PT, so that'll be pretty cool to wrap it up. But this will wrap up season 1, and then we'll start season 2, hoping in January, which I'm excited about. We have baby Q on the way.
Ooh, get her on the podcast.
By the time this is on air, she'll, who knows, a month old maybe, but this is it'll be exciting, that's for sure. So we'll take a little bit of a break. Papa Bear's got to spend some time with baby Q at home. Melanie's orders. All right, so let's get into this. So Alanna DiBiasi, and I'm going to allow you to introduce yourself. But what I have to say about Alanna is that I've known Alanna for like 6-7 years now. We went to PT school together. Yep. I graduated a year before Alanna did, and so saw you around. Did a lot with the pro bono clinic, the community pro bono clinic at Weidner University, from Staten Island originally, and super involved in the community is what I remember from you in PT school, as well as like into sports and orthopedics, and good heart, and also involved in the burn unit at Crozier with the military. So I'm taking your thunder. Go for it.
No, that's okay. So I was in Weidner University's 3+3 program. I graduated in 2015. I headed to go train with the Army Burn Center in San Antonio, Texas at Fort Sam Houston, which is actually the only burn center for the Department of Defense. So I trained there for the year. Then I headed back to the Philadelphia region, worked at Nathan Spear Regional Burn Center at Crozier, burn ICU, step-down wound care. And then I was contacted by McGuire because my clearance was still active, which is an Air Force base in New Jersey, and treated all active Army, Navy, Marine, Coast Guard, to get them back to deployability status in the outpatient orthopedic world for the medical squadron. And then here I am. So now I'm at PTW working with sports, which I've been really interested in. So it's been great.
We are more than happy to have you. You've been a pleasure to work with and learn from. Anything wound related, I feel like, or even like incisions, anything. I bring you over right away. Father-in-law, everybody. But it's been cool to get your perspective because of the number of overuse injuries that you've seen, and what better than endurance runners. So this is right down your alley. I'm excited to get into this with you. So how are we going to start this, Melinda? What do you think?
Honestly, I have so many questions just being a runner. Like even me, like I work here, so I run on this Ultra G all the time. One, I didn't even know that an Ultra G existed. Didn't even know what it stands for. And in case you guys don't know, that basically means it's an anti-gravity treadmill. If you can get on one, I suggest you go get on one because they're really freaking cool. And just running on that has like changed my perspective on running, let alone changed me as a runner. What I want to know is specifically from you guys to start off this conversation, because Alanna, I know you work a lot with runners. What do you find is like the biggest thing that runners do wrong that cause most pain in their legs? Because I personally suffer from pain in my hips all the time when I run, and I don't know why. I don't know what's causing that. Like, what do you look for?
Sure. So I think that me and Mike could both kind of answer this question, but I feel like what you're saying, a lot of runners don't know what they're doing wrong, and that's why they get here.
Yeah.
Because they're not really sure how to activate the appropriate muscles, the stabilizing muscles, in order to stabilize your body to be able to maintain the endurance while they're running. So I just feel like, especially with the younger athletes that we've been seeing in here, the younger runners, you just see how they're running, and I just feel like their gait cycle is pretty impaired from when they're running. So there were two people that Mike and I actually were looking at tonight in the clinic, which I really want to get Mike's perspective on those runners too. So
yeah. And then another question with that is like, I mean, we're talking about sports, so like almost every sport you're running, does that change? Like what you look at when you're looking at a soccer player versus a baseball player who's just running from base to base, or like a long distance runner? Like, do things change?
The mechanics of running stay pretty consistent throughout different sports. What changes are utilization of muscles based on posture. Like that's a nerdy way of saying based on your position, you're going to use different muscles, and based on the direction you're going, you're using different muscles. The principles that stay the same are that where your foot strikes the ground has to be in a position for you to propel yourself in that intended direction.
Gotcha.
Right? So if I want to cut to the left, then I have to push off my right leg in a position that's going to allow me to generate force, but also absorb shock as I get going. So I think to touch it, slight based on your previous question, it's poor absorption of shock and forces, where that foot contacts the ground outside of your center of mass is what is most likely to result in injury somewhere along the chain, right? So whether it's the knee, the foot, the hip, and then up the chain, there could be mechanical dysfunctions based on posture, how we sit, what we do every day, that are going to result in how the foot hits the ground.
Gotcha. Yeah, because I mean, like that brings up, I used to be a soccer player, so anytime I'd cut the ball, like if you're cutting on, let's say your left foot, is that because you're wanting to go right? So basically you're saying the way my foot strikes the ground is what's going to either cause me pain or cause me to go the way I want to go.
Yeah, essentially that's what's happening, because when you go to cut to your right, you're pushing off your left foot. What's the glute doing in that position? Is where that foot lands, what position are you coming out of, and how is your foot hitting the ground? That's going to cause your glute to activate a certain way, right? So maybe in that position, you're putting a lot more stress on your glute medius, right? Which is the ACL protector, is what I would call it.
Yeah.
In that position, how is that glute activated? Is it used to being activated that way? How fatigued are you? What's going on with your eyes? Are you looking somewhere else? Are you about to jump? So that all factors into what muscles are being recruited and in what position the body's in. If you're bent forward, you're going to depend more on the glute, right? And then forces may be more outside the center of mass because now your mass is distributed differently because you're bending forward.
then you use more effort to get there, and a lot of the part is like efficiency of running.
Yeah.
So even like stride length, or when you were talking about like if you're not in the maximal position that you should be in, you're just going to use more effort, and then that's going to decrease endurance. It's going to decrease the muscular endurance to hold up.
Yeah.
So that's how it kind of starts to work.
So it seems like there's like a lot of things you guys have to look at. It's not just like your foot hitting the ground. It's like your foot and like your glute and everything like that, where your head is, the direction, things like that. So how do you look at that in a patient?
Yeah, go ahead, Alanna. You got it.
So Mike has actually brought this to my attention a lot in videoing the running, so you can then replay it after and slow down the motion. I think that's really helped me since I've been here to really focus on people's gait and how they're functioning. So I've been doing that a lot more recently so that we could replay it and look at each spot from hip, knee, ankle, the thoracic spine and how it's rotating. So we've been doing a lot of that. And even tonight, I had Mike look at this one runner with me because she was toe running really bad. And then even that's a huge, huge question with so many people. Do you change the gait? Do you change, should people toe run?
Yeah.
Should they not? And I think that's become a huge conversation in running.
Yeah, because I always thought it's better to run on your toes. Is that true? False? Like,
So what happens is that we are trained. Some athletes are trained as field sport athletes. And field sport athletes like soccer, football would be an example of that. Tennis is more court, but there's change of direction. To move quickly and explosively and change velocity and acceleration, you have to strike on your toes, right? If you're going for short distances.
yeah.
So if I'm sprinting, playing football, like I want football players to spend most of their time on their toes. Functionally, that's it's not necessarily appropriate for long distances. That's not attainable for long distances. So what happens is you have these field sport athletes, even court athletes. A basketball player spends most of their time on their toes. You jump by taking off from your toes, and then they transition to long distance endurance athletes.
Gotcha.
You know, when they're like in their 20s or 30s or maybe even earlier.
Yeah.
Right? And then now here they are. They've developed these running techniques and habits, I guess you could call them. And then they apply that to long distance running, and then they experience injury because that pattern of running is designed for that specific sport, not for running long distances.
Yeah.
Right now, in the perfect world, you are able to like forefoot, heel, use it like a spring and take off. But the reality is everyone runs differently.
Yeah.
What works for you works for you. Our foots are designed differently. Some people are flat, some people have high arches, and our foot will accommodate or may accommodate, hopefully not too much, for their shape, and the muscles above it will compensate as well to make sure that the forces are distributed differently and you're able to run efficiently.
Gotcha. Yeah, that actually makes sense, though. I never even thought of that. The fact that running for different sports and, like, running long distance changes. Because I think that's something that I went through, like running for soccer. I always run on my toes. That's even track. I was told run on your
Actually
toes.
super ironic.
And it's even, I think it's even funny too, because like even when you're talking about gait versus running, like really like when you're walking, your heel should strike the floor and the force is supposed to dissipate from your heel, go around like the lateral aspect of your foot and then go to the forefoot. But then when you start running, things start changing. And I just think the younger population, they have a hard time with injuries because they're just doing things without the preventative aspects and the stabilizing aspects of the body.
So I would like to talk about what we look at. Like,
Yeah, I was going to say.
So what's interesting about it is and I want your take on this, Alanna, because I feel like we've like talked a lot about it, but philosophically maybe not as much. But like I start with like, all right, but like what brings you in today? Like, what are your goals?
Yeah.
Before I try and like diagnose you and tell you what you're doing wrong and what you could be doing better and find out what the source of your issues are, like I want to know your perspective on, okay, what's new with you? Every good evaluation or initial assessment comes from a good history. So we got to find out what's changed. Is it footwear? Have you changed your footwear? Like it could be anything. And we have to get those answers to then create an angle. So is there anything that you're doing differently each eval or each initial assessment for a runner when you see one? Like what's different? Like what's the variables that are changing each time when you're working with somebody? Is there anything in particular that sticks out?
With different patients, like each eval, or are you just saying?
Yeah, like so something that would be consistent would be like I'm going to do the same screening.
Yeah, no, I really don't. I wouldn't say I do the same screening. I like to be like systematic and regimented so I don't miss anything or whatever it is. But I'm just one of those people that's super regimented in a lot of different things. So it's not that I don't go outside the box, but it's like I want to hit all these things that are really important. And if there's other things I'm seeing, I'll just keep further testing it while I'm actually doing the eval itself. So that's kind of how I operate. But the history is the most important part to me for sure. And so many people will tell you that because you have to really figure out how did they get here? Why did they get here? What other things are they doing outside of their sport too? So what Mike was saying, like change in shoe wear, it's even did you increase your running distance? And a lot of this time, like everyone's like, oh, during quarantine, I upped my mileage by X amount and I have a stress fracture. Well, of course, so that's what we've been seeing a lot. But
So would you say that like changing distance, perhaps, you should be changing things when you're changing little things like distance or speed? Because like for me, I started running I went from 3 miles to 6 miles, but I didn't change anything that I've personally been doing. And I feel it. I feel like more fatigued. I feel more in pain. Like I'm sore after running these long distances. But then if I run 3 miles, I'm like fine. So is that because I should be changing my footwear? Or I should be doing like certain stretches before or certain workouts after? Like, does that all affect? Do you guys look at that stuff?
Yeah.
go ahead, Mike.
Yeah. To me, that's programming.
Mm-hmm.
So, how are you progressing your training regimen, right? How are you supplementing it? Are you supplementing it with strength? Are you strengthening a strengthening program? Are you doing short distances during the week, long distances on the weekend? So that's all going to affect your ability to run longer distances. Mm-hmm. My interest is what kind of jumps did you make? How quickly? And then what other things were you dealing with? How were you sleeping? Right. Diet?
Yeah.
It could be anything else.
Yeah, and even like running every day. Like some people will run every single day, and even really optimally, like to get your best chance or like force of production that you're gonna have like optimally, you really should wait like the 48 hours after to like go do like if you're gonna do your second long run or whatever you're training for. So that's one thing that I've kind of picked up when I've taken this running course maybe like 2 months ago now. So they were just giving ideas of like how much you really should rest and along with strengthening, because running doesn't make you stronger. It's the strengthening you have to do on top of it in order to make you strong enough to be able to continue to run quickly and efficiently. So,
Can you say that one more time?
Did you not hear it?
I did. I just want to hear it one more time about the strength piece.
I want to
reinforce
running does not get you stronger. Like if you run every day, that's not going to strengthen your legs. So really what you have to do is strengthen your legs, strengthen your upper body, your core, and that's what's going to get you stronger. And then once you get stronger, you'll be able to quicken your speed and propel the forces and your force production more. It's from your muscular production.
Now, see, that's interesting because me personally, I would never think that. I mean, obviously you understand, okay, if I make my legs stronger, I'll be able to open my stride longer or like push faster. I don't know, something like that. That's what would go through my head. But for me to like work my upper body strength and you tell me that's going to make me faster as a runner, how? That,
Yeah, I mean.
Go
ahead.
I was just going to say, even the other thing, I think that people think, like in life, like we're all like, if I do more, I'll get better. Yeah. Just with anything. If I study more, I'm going to pass the test. If I read more, I'm going to get better at this.
If you run more, you're going to be able to
So people think
faster.
Repetition, okay, I'm going to beat that time yesterday. Well, you might just be really fatigued from yesterday, so you probably won't. You can, but it's just like people, I think, get like, if I just repeat and repeat and repeat, I'm going to get quicker and better, but it's not how it works.
So you recommend the strengthening. Like it needs to be done.
Strongly recommend. Because I use the analogy of like a gas tank, right? Like your tank is only so big naturally. You can expand the size of your gas tank because you can tolerate more by getting stronger, right? And then your strengthening program, maybe it's high rep, maybe it's more explosive, so you tolerate different things differently. So the key is that if you can strengthen it, you build a greater foundation to tolerate these forces that you're putting through. Like running is walking is controlled falling, right? Like running is explosive falling. Like if you push off with one leg and you don't bring your other leg with you, you're gonna land on your face.
Yeah.
So like you have to understand is like that is force being absorbed every single time, no matter how slow it looks. So you build the foundation to get stronger, and you can tolerate more. In addition to building your cardiovascular component and doing your shorter runs with some breaks in between, with long runs on the weekends. There are plenty of programs and resources out there for you. We're happy to offer some of those as well here. But yeah, that's a great point, Alanna. I can't hammer that home enough.
now this might seem like a weird question, but I was told that if you, I have two questions. Running outside versus running on a treadmill, you should be doing things differently. Is that correct? Like the way you're running?
Well, I wouldn't say it's the way, or I think it's more like, I feel like it's more when we return people to running. I feel like I'm cautious with that. Like, I don't want them running on the road when we're returning them to running.
Gotcha.
Like, I'd want them on a soft track first or a treadmill first before they're returning to running. But I don't have people run differently.
Is there a reason why you would want them on a soft track or a treadmill?
Less force, less
Okay.
pounding,
So it's like
less
springy.
repetition. Yeah, and it has bounce back that they'll be able to get that and not put all their force into the concrete or whatever it is.
Okay, because that, like, people say all the time, it's not good to run on treadmills. Or if you do, you can hurt your, like, knees. Or you can hurt your legs.
I don't know how I feel about it. It's more functional to run outside, right? Like I think everyone agrees on that. The challenge is, as a therapist, it's tough for me to monitor what they're doing wrong when they run outside. For me, at least, you need to have a super keen eye to see what a runner's doing wrong on the track because they're moving away from you, right? Like when they're on the treadmill, yes, the speed dictates their pace. But if you can count how many steps you're getting in a minute on the treadmill, you can see how that foot's striking the ground. What's different is they don't have to propel with as much force against the treadmill because the treadmill's moving, right? You have to push with more force outside.
Yeah.
So that's what's different. The absorption
And the elevation.
And the elevation,
Yeah.
right? True.
Yeah.
You have
Like, that'll
elevations
get you
outside,
too.
uneven surfaces.
Yeah.
So, I mean, it's more functional to get outside.
Yeah.
I think that's a great point. When you start them in a more controlled environment and then get them to a more uncontrolled environment.
And that's how I really try with the military, with the soldiers, because like they'd have to run 1.5 miles, depending on what branch you're in, to pass their test in order to deploy, right?
Yeah.
So like totally different from certain people here. But I had you were on a time crunch to get them to run that, but I didn't want them running on the concrete first. I'd have them go to the track first and start building themselves back up to it before I had them return to the road. So
Yeah.
Mm-hmm.
Because,
Go ahead.
oh, no, you can go.
I think I'm going to dive into some of Alanna's deeper thoughts on this. So I want you to shoot.
Oh,
Yeah.
no, I was just going to say, because my second question was, I've been told to swing your arms more. When you run, it makes you run faster.
Yeah,
Tell me, is that truth or is that a lie?
So when
we
you
need to
swing
know.
your arms more, you're going to have if it's a greater arm swing, you're going to have a greater stride. But typically your arm swing is dictated by your stride. Like, that's the truth.
Okay.
So you would hear this all the time, and now I hear it in I hear sirens. Stride it out. No, don't stop striding it out. Like, that's bad for you. You are intentionally putting runners, athletes, whatever, in positions where now they are not absorbing forces normally, like they should. So now you're redistributing forces up the leg, up the spine, and God knows what is taking the brunt of that. So don't stride it out. When you stride it out, you're going to have longer arm rotation or arm reaches, arm swing, and then you're heel striking as opposed to midfoot striking, or normally you're in a sprinting sport, so you're toe striking. So, So what's going to happen is, as you stride out, now you're going to have bigger arm swing. So the frequency at which, or cadence at which your feet hit the ground, will dictate your arm swing. And watch the elite. Watch a marathon. I know it sounds boring to some people. Melanie watches them all the time. It kind of drives me nuts, but I study it now. Like the Boston Marathon or the London Marathon or the Berlin Marathon. Like, they're on TV. Yeah. Just like other sporting events are. Like at 1 a.m. So DVR them, watch them. You will not see the elite runners go with big arm swings, like hip pocket, eye socket type thing. That doesn't happen. They're short, they're steady, and they're you're not generating power with your arms in long distance run.
Yeah.
Watch a sprinter in a 100-meter run, or even 800-meter, whatever, shorter distance sprinters. They have arm swing, right? Because they're generating more power, and their lean is different, so they have slightly longer strides. So. Does that help?
That makes way more sense.
I want to figure out, so get me into the eval, right? So you get the history, find out like what the source of the issue is or what the primary complaint is, and what that individual's expectations or what their goals are, right? And then you do a screening where you have a system, which I love the system, of different movements that you want to do to help identify what exactly. What is the goal?
What is the goal
of the screening?
Yeah, like where are they having, it's more like a functional screen, like where are they having functional weakness? That's what I think I focus on you do too.
Yeah.
You know, a lot of us in here are focusing more like where's their functional deficit, because why aren't they holding up functionally versus manual muscle testing, which you like get them into the position and test them there, but that's not telling you anything about how their entire limb is holding up while they're doing a functional motion. So I feel like a lot, like in here, a lot of us are doing more, hey, let's see how they do a squat. We're looking at their heels. Is that touching the floor? Is it not? Single leg stand, single leg squat. We're pretty much doing a lot of bridging, activities like that, looking at the core, how's the knee lined up. And that's going to tell us more from that test, because it's the endurance of these muscles holding up while they're running. Instead of just doing a quick manual muscle test, that's not going to help us that much with someone who's like a high athlete. Yeah.
So for some clarification,
go ahead.
Manual muscle test, for some people who may
Go
not
for
listeners who don't know, is a systematic approach to assessing the strength of a muscle that is a way to isolate that muscle in a non-functional position, right? Some of them at least. So for example, for the glute muscle, the glute medius, for example, we talked about that being the ACL protector, that controls rotation of the femur. So when someone lands on their foot or like lands on a leg, the knee goes in, that's controlled by the glute medius. That is assessed lying on your side, kicking a leg up, slightly extended, so slightly backwards. So the foot that you're assessing, the leg that you're assessing, that toe is probably by the other foot's heel that's underneath, so you have a visual, and you're pushing down at the knee. And you gradually increase your force to a point where you can determine how much strength they have. It's 0 to 5. Right? 0 is like, couldn't lift it up at all. A 5 is, I couldn't break them. Like I couldn't move them at all. So like how functional is that relative to someone doing single leg hops for distance where you look at the knee going in, right? That's tough to measure objectively unless you have angles and all that stuff and electrodes. But it gives you more information that's functional that you can apply and say, okay, they tested 5 out of 5, but when I do an assessment to look at a functional assessment to look at the glute medius, such as single leg hops, for example, or jumping off of a box and jumping up in the air and then landing on the ground and the knees go in. But how much value does a manual muscle test have? And I think you and I both agree it doesn't have value. Yeah.
And I feel like in here, like again, with higher functioning athletes, or if they're going to get that 5 out of 5 out of each, well, if you get 5 out of 5 on all of these, well, what you're finding no deficits then, which is not the case, right? So like you have to go look for that problem. But even sometimes I will test the glute med, like I'll isolate it and do that. And if they can't hold it up there, I'm like, okay, then they can't even hold this up here. So I'm like, that's a problem, because then how are you running with that muscle you can't even hold up? But you like different in the sense here versus say other settings, right? Like say if someone has a stroke, you're in an ICU or at a burn center, you're going to pull out those tests because you're just seeing, is that muscle activating, right? But then as people get more functional, you're going to start doing more functional testing.
Yeah, so I'm going to use the screening, like you had mentioned, to identify weaknesses as well as deficits in mobility or stability, right? Like how stable is that? How explosive is that? Are these limbs and what's happening up and down the chain? I love to videotape them. I think I have like a sharp eye, but I miss things all the time when it happens quickly. So the videotape allows me to slow it down and identify, okay, what muscles aren't working at what angle. So do the screening, love it. Have a systematic approach where you will not miss anything. For example, the overhead squat. You do the overhead squat in your screening?
Yeah.
Tell me about the overhead squat and how, so people can have an idea of what the purpose of the screening is. And what information you can gather from it.
So I feel like when I do the overhead squat, I'm looking at both their heels, like do their heels touch the floor? And if not, like why aren't they touching the floor? And it's probably because of like gastroc or soleus tightness. And then you just differentiate that out and then go test that. But a lot of times you'll notice on the injured leg, they're not squatting into that side of the injured leg. You'll almost see them shift to the opposite side. And that's when you know that they're not using that other limb. And they don't even know they're doing it. You put them in front of the mirror, they're like, oh, okay. So when they squat, they shift to the opposite side that they're not, the one that they're not in pain with, and they'll put more weight through that leg.
Yeah.
So that's what I look for.
Yeah, I love that test because then you can tease out certain
Exactly.
things. Right?
Even the thoracic, like you're looking at the lumbar spine then too, because you're seeing how arched is their back during that point, and then that's telling you a lot about posture, along with their thoracic spine. That whole squat is telling you a lot about how the patient performs.
Yeah. So if they have a stick overhead or a bat or something like that, right? And when they go down the squat, if it goes like beyond the toes, is how I was taught at least, then something may be up with the thoracic spine, right? So in phase 2, hand behind the head, forget the stick now, right? Hand behind the head, squat. If they can do that in like they don't go on their toes and the toes don't bow out or point out, and they get to parallel, like, all right, like thoracic spine is the issue because it looked perfect when thoracic spine wasn't stressed.
Right.
If that still looked like crap, it's like, okay, they're still going up on their toes. Now I'm looking at the calves.
Yeah.
Right.
So it's helping you kind of figure out what's causing them to go onto their toes and why they can't stay on their heels.
Or if they're not getting to the depth, or if their toes are pointing out. So it's a series of movements is the goal of the screening, to help to identify what the source of the issue is.
Sure.
And your head squat's unique in that modifying things throughout the movement will help you to identify what the source is. And then you treat that source, right? So in this case, it was perfect when the hands went behind the head as opposed to when the stick's overhead. I'm working on the thoracic spine. And now I have them do it with the bat overhead or the stick, and it's perfect.
Yeah.
Okay, thoracic spine's the issue.
So, but then you're saying that helps them when it comes to their running as well?
Yeah, so then we have to test that too, right? So principle, and I want you to touch base on this too, is like treat, or you have to test, then treat, then retest. So I do this like literally with all my patients. Any good clinician, please, like young clinicians, please do this. Find out what the issue is. Like find out what is the movement that is causing pain. We call that an asterisk sign, right? That's what I call it. And then from there, once you do that movement, then treat what you think the deficit is. Use one technique.
And that's that's like the biggest thing, is to use one technique, because then you don't know what worked or what didn't.
Right. So if you're doing 10 different techniques, then you don't know what helped. Exactly. And then after that, then retest it. Right. So this is awesome. This is live. So like we're getting the phone ringing in the clinic. That's cool. So like then you retest it. Did it improve? Did it get better? Did it get worse? Did it stay the same? And then if it worked, okay, let's do more of it. If it didn't work, okay, let's try a different technique to address that deficit. Yeah. So because then that justifies why I'm doing that technique.
Yeah.
That's major. So please do this. Like that's major. So anything else you want to touch on with that?
Not with that, but more just the other thing that I think I've noticed a lot, and I've been taught to as well. Like we all function in one plane all day. Like we do everything forwards. So we're on our computers. When we're in the car, we're operating in the one plane. When you're running, you're in one plane. So we're always in this one plane and using like our anterior chain, like the muscles that are in the front of our body, and not the muscles that are in the back, the glutes, the hamstrings, and what we use for push off. So I think everyone like being on laptops now in this technological world, and everyone just focusing on what's in front of them, that's a problem too, because then you have a lot of people coming in with weak glutes and weak hip abductors because we're not walking to the side during the day. We're not using them. We're just using everything forward. So I think that tells us a lot too.
Amen. And that's postural dysfunction, right? So I think as a clinician, we need to be aware of what the postural dysfunctions may be. In the end, like you said, our screens are going to guide us what to treat, what to look at. So we do so what's next? Do you have every runner, if they're able to, run on the treadmill and you assess them? Are you doing more dynamic screenings? Like, so you do your movement screening. Do you address that issue after the screening that you found, or do you watch them run and then try and treat them?
That's a good question. I feel like lately I've been trying to treat them and then have them run, but I want to see how they kind of function normally. Like on the first eval, like I want to see what they're doing. So I'll usually do a movement screen and then have them run if they're not in serious pain. So if they're fine, I'll do my screen and then I put them on the treadmill or on the turf here and see what they're functioning like before I go in and try and fix something.
Yeah, that's a great answer, because I think you can go either way on that, in my opinion. The treadmill for some is a way to train somebody how to run and isn't the same as a cross-country runner running outside, right?
Right.
So what exactly is the best thing to do? And is it safe and appropriate for them to run? Maybe it's not.
Right.
So you can't always run them. But I like to try and see, especially if they've been running on the treadmill, a no-brainer, get them to run if they're able to, because then it tells me, okay, what's going on when they're actually running? Like, it's nice to see them do a squat, and it's nice to see them do balance, and it's nice to see them do lateral lunges and forward lunges and so forth. But how does that equate to function?
Exactly.
So let's see you on the treadmill and then go into it from there. Look at the wear of the shoes. Is that something you do?
Yeah, definitely.
Okay. So when they're on the treadmill, is there anything that you look at in particular?
I don't know why, but I just focus on the feet first. I think that's just where my eyes technically go to. But again, like I've been using the video more, which has helped a lot, because then we'll put it in slow motion where you could really see everything from where their foot is hitting, how even their foot is ending up, which is really important. So I usually just go from like the feet, the knees, and the hips. Like that's like my main focus on the day. So when we're first assessing them.
Yeah, I've seen a couple of you guys watch people on the treadmill and on the Ultra G as well. But I've noticed that you guys will look at foot swing, like if someone's foot is swinging outwards when they're running. I just don't understand what is that. Like, why do you look at that? What's the cause of that? Like, why would that happen?
Yeah, that's a good question. So what I look for is asymmetries, right? So just like Alanna, whether you start at the hips and go down, you can't ignore the thoracic spine or shoulders or what have you. But you have to start somewhere and work up or down. You can't start at the knees, in my opinion, right?
Right.
So let's say we start at the feet. What I'm looking for is asymmetries. So is one foot landing more curved in? And I want two angles. I'm pretty sure you do the same.
Yeah, I go back and side. Yeah.
Back and side view. Front view can be helpful. Most treadmills have a bar in the front, so you can't really see the knees come through anyway. So posterior angle, so from behind, and then a lateral angle. And the posterior angle is going to tell you where they're moving. We call it in the frontal plane, side to side, right? So if a foot is whipping out like you're describing, Melinda, that tells me at what point is that happening. If it's happening when the knee is starting to go forward now, to drive forward, now I know if the knee's starting to go out, TFL, like a lateral hip flexor muscle. What muscles are being activated when it's going out that way, right? And what position did it leave the foot? Maybe it started going more outside or lateral, like while it was on the ground going backwards. And then when it initiated the movement forward, what muscles are activated? So I always try and think of it as systemically as possible. And what position are the muscles, and what is the driving force, and then what would cause the deviation? Then I can try to address that, right?
Yeah.
So more often than not, it's either the foot or the hip, and go from there. So it could be gastroc, could be glute, could be a bunch of different things. So in that position, I can look at the hips. The hips may lean side to side. The foot hits the ground, and that hip drops, or maybe it drops the opposite direction. That tells me that may be weakness at the glute, and then that would cause a down chain effect to the knee, going inward, the foot collapsing, so forth. And maybe that the foot is collapsing in the knee, and then the hip happens.
Yeah.
So chicken or egg, right? Like, do we go after the glute medius first, or do we go after the foot control, right? The intrinsics of the foot. Maybe it's gastroc tightness, so the foot's landing in the side view. You can see where that foot lands, right? So I know I'm running on here, but to me, this is like super important that you address all of these contact points up and down the chain.
Yeah.
So from the side view, I can see which foot is landing, where it is relative to the nose, and so forth. So do you have anything else that you would look at, like from a side view? Are you looking at like, so like contact point, like where it's the foot striking? Are you looking at like, okay.
Yeah.
And so not only how far out in front,
And then where are they striking the foot, and the symmetry of it. Yeah.
What does where they're striking the foot have to do with their running posture? Like, what does that tell you?
It's more even. I think it's more even like looking for, okay, like today when I was watching two of the running people, like why is their left foot over pronating so much? Meaning like their arch is really going into the ground and there's too much motion there. So it's like, why are they over pronating at that spot? So that's what I'm looking for a lot of the time too. And then their foot's going to hit the ground differently.
Do people do that on one side versus the other? Like, do you look, is one foot
Sure.
doing over pronating, like you would say, versus the other foot?
Yeah, to me, and I want to get your take on this, and
Yeah.
and everyone's different, right? It all depends on their pain. So the foot that isn't injured, more often than not, is going to be the normative foot,
Correct.
right? So you want the affected limb or leg to look like what's normal. So if the normal leg is doing something like pronating a certain amount and it's striking at the heel, but it's coming across at a certain way, and the other foot comes in that's of the injured limb, let's say it's the hip that's injured, and they have more of a curve when they strike, well then that's not typical. Why is that foot pointed inward or curved up as it goes to hit the ground?
Yeah.
And then how's that going to affect? So when that foot does hit the ground at that angle, how does that affect the knee? How does that affect the hip? They all have to adjust up the chain. How does that affect the low back, right? They all have to adjust up the chain based on how that foot hits the ground. That's super significant. So if that foot hits the ground differently based on how that swing is happening and the foot hits the ground and the rest of the chain has to accommodate that excessive curve or lack of a curve or that position of the foot, then that's going to have a huge impact on how that affects the muscles up the chain.
Do you find that a lot of runners, or like even athletes in general, depending on how fatigued they get, their running form changes, and like that can cause pain and like damage?
I think so. I think that's one of the biggest things. That's why people do get in pain, because they don't have the muscular endurance to keep their limbs, like to hold their bones in place in their right position while they're doing higher level activity.
So that comes from strength. Like, would you say it can also come from
stability? It's more like the stability of the body, and then dissipating the forces of these muscles we're talking about, these smaller muscles that we are working a lot in physical therapy. It's all just physics, that it's like, okay, if you straighten this, that'll dissipate the forces on the bone, pull it out, and then that will allow you to have the proper motion.
For how someone runs and their stride length, that's going to change over the course of a race, right? So when you're fatigued, you take longer strides.
Yeah.
What happens then? We said this probably 10 times already in the podcast. You're going to absorb forces differently.
Yeah.
Muscles are already fatigued, so now they have to absorb different, like excessive force than they're used to absorbing. Than they did the first 20 miles, and now there's injury.
Yeah.
Right? So to me, that's like almost simple. And that we overstride when we're fatigued, and now crap's really going to hit the fan, and you got to finish the race because there's 2 more miles left, and you trained all this time, and mom and dad are waiting for you at the finish line and everything else. So to me, that's a big one. And so what do you do about that? You make sure you train the right way, right? You make sure you get the right muscles activated. You make sure you have the right flexibility. You make sure that is an appropriate distance for you. And then you also know you have to know when to hang them up. Right?
Exactly.
Like there's some patients where I just got to be like, listen, I'm not going to stop you from running. I think you feel this way too.
Yeah.
I'm not going to cut you off. I'm not going to, you need to get the exercise. I get it. But you're not going to be running 10 miles every weekend.
Right.
Yeah.
We'll get up there. That's the goal. You know, I have a patient who's literally started at 2 and now he's up to 10. He's going to do the half marathon.
Right.
You know, hopefully, within a month. That's virtual.
Virtually. Yeah. Virtually.
Virtually, let me know.
Yeah, it's just going to be on my treadmill.
Yeah.
Just take my time over the course of 6 hours.
Could you imagine? Video chat, everyone.
But I think that's a big piece of this, right? And that's education. There's a lot to it. But there's so many variables, is I think the take home here, that this is not a perfect algorithm. Anyone who thinks that there's a perfect algorithm to assessing runners and treating runners is out of their mind. There's different things to look at and different ways to think about things. But I think that's my big takeaway. Is there anything else I'm missing? Would you recommend exercises at the end of the evaluation?
Yeah, I always go through a home exercise program with them after, just to get them started. Nothing crazy, because you don't want them doing the wrong form at home. So I just it's 3 things I give right off the bat. Okay, what were their worst things, and what do I want them to nail down before they come back next time?
Yeah.
But it's nothing It's nothing crazy because, like I said, I wouldn't want them doing something wrong
Yeah.
for the next few days before they come back.
Single
So,
leg pistol squats.
yeah, it's like
as
just
your first
activating
yeah.
these muscles we've been talking about. You know.
What other questions do you have about that? Because I agree with you. We wrap up with exercises, and then a game plan, right? We educate game plan, but those are the big takeaways. So subjective. You have a screening. If you want to implement treatment, then you can.
Yeah.
Or you can.
Which I typically will. Yeah.
Yep. Video, and then the video on the treadmill will lead to maybe treatment. So those two are interchangeable for me, and I know it seems like they are for you.
Yeah.
And then game plan, exercises.
Right.
Right?
Exactly.
Yeah.
And then record it, right? We have documentation. We record it, especially the screening, because we can use that screening as an objective measure, meaning a 0, 1, a 2, based on the screenings we have here and the ones you use. And we can use that to reassess how Melinda looks in 3 weeks after treatment, and how she feels is also, obviously, that's super important, what her mileage is at that point, and how that ramp up occurs so you get back to your goals.
Yeah. No, I mean, I definitely resonate with you guys saying that it's not just like one set plan, because just watching the different runners that we have come into the clinic, I see every single one of them doing something different. And you would think like, oh, I'm going to PT, my friend goes to PT, we're both runners, I should be doing this, I should be doing that, because that's what they're doing. And I've noticed like, no, that's not the case. Like every single thing is different.
Right.
And I just don't think people like realize that. Even like your sport, like that's going to change what you're doing when you're at home versus in the clinic training so that you can run for that sport. So I think that's a big takeaway too, is that you shouldn't, just because your friend's doing something or someone on your team is doing something, doesn't mean you should be doing that same thing. You can actually be hurting yourself by doing that.
Agreed.
Especially with nowadays people on like following people on Instagram.
I was going to
like
say.
So
Pinterest.
that's a great takeaway, is know your body and get it looked at. Like if you think something's wrong, get it looked at and get a program that's for you.
How many times have you heard, I wish I would have came in to see you sooner? Like that's flattering.
Yep.
But no,
All the time. Tons of injuries.
Yeah, I'd rather you see me 3-4 times than have to see me 15, 18 times, because now you have a torn muscle.
Right.
Right. Or there's some type of arthritis and now you have other issues going on. So, or a fracture, God forbid, a stress fracture. So what else am I missing? You guys got anything to add?
I think that's
I don't think so.
I got
think
one
I'm
last
Yeah.
piece I want to add on this. And here's a pearl. Multidisciplinary approach in terms of segmental approach. Right. So like if it's knee pain, I'm looking at the ankle, I'm looking at the hip, I'm looking at the lumbar spine. That's a point of having a screening the way you're talking about, because you don't miss anything then, right? And that goes to what you're saying, Melinda, about how everyone is doing something a little bit different based on what their deficit is, right? So we have long and tall runners, we have short and stocky runners, we had, like, everybody runs.
Yeah.
Everyone has to run a little bit differently. They may have different deficits as a result. So looking at, for young PTs especially, you got to look at everything. If it's elbow pain, you're looking at the shoulder, you're looking at the thoracic spine, you're looking at the rotator cuff, scapula, the tightness of the pec. If it's a runner and it's a lower limb injury, you're looking at the ankle, you're looking at the foot, you're looking at the big toe.
Yeah,
There
exactly.
you go. How about the big toe
Yeah.
getting some love in this podcast?
Right.
And
Yeah.
seriously,
It really matters. It's
like-
crazy,
Talk about
but
it.
like,
That should
but
be
it's
its own
funny
podcast.
because like even when I was like a new grad, like I feel like I didn't assess as like now you're like, okay, like now you realize like all the stuff that comes into it. But Mike taught me that to keep looking at the big toe.
big toe, I'm telling you right now, you turn on that big toe,
Yeah.
your glute, and Jen is just smiling.
Jen
listening to
is
this right now.
smiling. Yeah,
I'm not going to lie.
The
That
foot.
should be the title of this podcast.
Is the big
Runners,
toe.
the big toe. How's
Runners,
it
the big
working?
toe. Yeah, exactly.
Check your big toe at
Yeah.
the door.
Oh my
Check
God.
your
That's a
toe.
dad joke.
Yeah,
Check your ego.
You're
at
not
the
a
door.
dad yet.
Check your
Okay.
big toe at the door. I'm getting
I
warmed
know
up.
he's making all the
Getting
dad
warmed
jokes.
up. But yeah,
He has been.
I told you I'm warming up. Jervis sent me a couple the other day.
Oh, nice.
They're awful. But yeah, so looking at above and below, at very least above and below one joint from the injured limb, right? So above and
Yep.
below the injured limb, at least above and below one joint. Go 2 joints. Look at the low back and the hip for a knee, right? Look at
Yep.
the ankle and the big toe
Yeah.
for a knee. So and so forth. So fire. This was good. What do you think, Charlotte? Am I getting thumbs up from you?
Ooh, we got a
Thumbs
thumbs up.
up.
Is that a good? Is that like an A+?
It is.
Yeah,
So-
it's an A+. No, I'm just kidding. You got an A+.
Melinda Brooke,
Yes.
how do we get in touch with you?
Oh man, you guys could literally follow me on every social media platform. But
How much time we got here, Shelly?
yeah, I mean, I
2
don't want
minutes,
to. I don't want
3
to go
minutes.
too far over. I mean, we got the Instagram, the TikTok. Honestly, it's just Melinda Brooke across the board. We like to keep it nice, simple, and
Nice.
easy.
No underscores, no exclamation
No,
points.
just Melinda
no-
Brooke.
sorry. Okay.
Okay, tell us.
Okay.
Yeah.
Melinda Brooke on Instagram and YouTube, but on TikTok you gotta add a period in between the Melinda and the
Melinda
Brooke. I'm
Brooks.
sorry.
I don't
Getting
have
a little
TikTok,
complicated.
okay, but
I don't
the
know how do you
others-
get in contact with you guys and the podcast and PTW Newtown Square. You got any underscores?
I have an underscore, yeah, but that's it's not about
okay.
me. So go ahead, Alanna.
What?
How do our listeners get in touch with you?
I don't know. You had to get in touch with me?
Yes, with you.
Well,
Do you have an email
I
that
have
you
an
want to share?
email,
Do you?
yeah.
Okay. What's your email address?
Alanna, ALANNA, dot, my last name's tricky, but DiBiasi, DIBIASI, at ivyrehab.com.
All right, perfect.
Yeah.
That'll be in the show notes. Do you
Yeah.
have an Instagram or Facebook or anything you want to share?
Nope.
Okay, perfect.
That,
All right.
yeah, I don't have one.
All right, good stuff. This has been awesome. That's a wrap. Thanks for listening to the On Q Performance Therapy Podcast. If you like this episode, please subscribe on Apple Podcasts and Spotify. It would mean so much to me if you could leave us a 5-star review so more listeners like you could get this important information. See you next time.